really an opportunity for yourselves as attendees to ask some of the questions that you have around the COVID vaccination, and really to allay some of the concerns. We've got a panel this afternoon who hopefully will be able to pick up some of those points. As I say, if you have any questions at all during the event or any sort of issues you'd like to raise, you can use the chat facility to do that. And you can just pop a question on there, or equally, I can see some people have already got to grips with this, that there's a Q&A icon at the bottom of your screen where you can submit questions there, and they will be highlighted to the panelists. I'd just like to do some quick introductions. First of all, we have Director of Public Health, Stuart Keeble, who will be giving an overview of this afternoon's event. Somebody's got their sound on, I think, and there's a power tool going off in the background, but I will keep going. So Stuart's going to give us an overview and a brief sort of outline of some of the sort of key things around the vaccination. We're also joined by Juno Jesuthasan. Apologies if I haven't quite got your surname right, Juno.
That's good enough. Juno.
Okay, and Laura Mercer as well, and both experienced GPs who again will be able to sort of answer some of the issues that have come up surrounding vaccination. Also, mustn't neglect to mention Molly Thomas-Mayer. And Molly and I will be keeping an eye on the chat and your questions, and just keeping the conversation going when there's perhaps a little bit of a quiet spot. And also Claire Smith, Development Manager from Suffolk County Council, working within adult care services. And again, if there are some questions around perhaps the process as it is in Suffolk, Claire's on hand to just keep an eye on the questions as well and help facilitate conversation. So as I say, any questions you have, you can use the Q&A or the chat. Any technical difficulties, just email myself, christian@caredevelopmenteast.co.uk, and I will try and fix things as we go along. I will be recording this afternoon's event if you have to dip out, but just like to get proceedings going by handing over to Stuart. So Stuart, over to yourself.
Thank you, Christian, and welcome everybody, and thank you for making the time to come and take part in this webinar. So I'm just gonna see if I can share my screen. Right, I'm hoping that everybody can see that.
That's fine, Stuart.
That's great. So really, the idea today is, I mean, we know that there's a huge amount of information out there around vaccines, and lots of information going around. Some of it, I think would be fair to say as a panel, we'd find very challenging and may not agree with, others more helpful. And I think what we wanted to try and do was to try and bring some people together to have a bit of a discussion about vaccine and try and deal with some of the concerns, the questions, and really dip into some of the detail that you may want to know more about. I think ultimately where I want to get to, I suppose, the Director of Public Health, is to get as many people vaccinated as possible, because I see this as one of the most important parts of our fight against COVID and trying to get the rates down more broadly. But I do appreciate that people do have genuine questions and concerns, and very much I think conversations are really important as part of this. So this isn't about trying to hit you over the head. This is genuinely about us trying to impart the information and knowledge that we have, and trying to resolve or answer some of those questions. So please do feel free to bring forward your questions, and no question is a silly question, and we will try and do our best to answer those. So really, I'm kind of the teaser at the beginning before we kind of have some of the questions, but just wanted to try and work our way through some of the basics and just try and give some of the background to try and help get us in a good place to have some further conversations around this. So obviously we're all here to talk about the COVID vaccines, and obviously the concern is the coronavirus itself. And I think the reason why we're putting this effort in now and we want to have these conversations is the impact which you're all aware that COVID has had over the last year. And just in Suffolk, I mean, we've got at least 27,000 confirmed cases, but that figure, it will be a lot higher than that. At the beginning, we didn't test anybody apart from those going into hospital. And we know that at least 1,200 people have lost their lives to COVID. So clearly, it's had a massive impact. And the vaccine, as I said, is one of the key parts of how we can try and work our way out of this and get back to a bit more of a normal life that we had before COVID. But also the fact that COVID is not just affecting some of our very most vulnerable, and obviously we see the impact, and you will know very well from being frontline workers in health and social care, the impact that's had on some of our most vulnerable in communities. But it has, and it does affect other people. I think long COVID, the most recent data from the ONS suggests that about 1 in 5 people have symptoms longer than 5 weeks. And around 1 in 10 people have symptoms longer than an impact of 12 weeks. So this isn't just about how do we prevent ultimately people becoming very ill and dying, but it's also about protecting people more broadly. So we know that there are different risk factors around COVID, and obviously in the news, and we've talked about these more broadly. But with regards to the biggest predictor and the most impactful effect of the vaccine, age is still the biggest driver of who we need to protect first. But actually, we know that we have people like yourselves working in frontline roles, which does increase the risk of that, and hence the being prioritised in the early steps, and also other groups of the population. So for us, it is really why we want to drive up and get the uptake as high as possible. I mean, just briefly back to the very basics. That why are we using vaccines? So one of the questions I've had from somebody who was concerned about the vaccine was, well, why can't we just test our way out of this? Why don't we just test, isolate, and reduce the spread of the virus that way? And I think there's a couple of factors here. For one, the virus is extremely infectious, and it's not possible to just try and lock down and bubble down on individual groups. And the reality is that that to do it in the most effective way means that vaccines enable us to do that. And there's obviously a long history of this. So vaccines have been around and for many years, and going back actually to start to think about vaccines in about year 1000 actually in China. So there's a long history and understanding of the importance of vaccines, and ultimately this is a vaccine preventable disease, and there's a good history there around this. And ultimately what we want to do is we want to get to a level of where possible of herd immunity, and the higher the rates of the vaccines we get, the uptake, the more we cut the direction of which the virus can spread. And that's why when we talk about things like measles and other types of vaccines, we're trying to get up to the levels of around 85% and above, because actually it just cuts the path off of where the virus can go. So that's why very much the vaccine is part of our roadmap out of where we are at the moment. And in its simplest form, the vaccine is about training your immune system to get it ready, to be ready for the coronavirus if it happens to come towards you effectively. So by getting your body ready for that, it means it can respond better to that and put up a defense. And as I'll say in a bit, the virus is designed to reduce mortality, reduce death, and the most serious health outcomes. And by doing that, then it helps to protect us all. So very much it's about getting our bodies ready. So at the moment, there's 3 vaccines that are authorised in the UK, and these are Oxford Uni, AstraZeneca, so AZ as people call it, Mrna, and the Pfizer BioNTech. And at the moment, the main ones that we're using at the moment is the AZ and the Pfizer. The Pfizer was the first one to come along. Now, there's many different types of vaccines, and some of the more historic vaccines have used basically either a dead version of the virus to get the body, to train the body ready to response, or what's called an attenuated virus, and that's where it's still the virus has been reduced in its impact, and again it enables the body to respond. The current vaccines we have at the moment work in a slightly different way, and effectively this is really about training our bodies and working with our cells to produce some instructions on how to make a piece of the protein that represents part of the virus, and then the body then produces an immune response against that. And although these are relatively new technologies, they have been used to develop other types of vaccines. So the viral vector, the AZ vaccine, the same method has been used more broadly for reasons such as an Ebola vaccine. And also with the RNA vaccines, the technology has been used for a while. For instance, they've been trying to look at how they can use this approach for things like preventing cancer. Now, the actual treatments they've been trying to do for cancer haven't worked, but actually those approaches are safe. And I think that's the key bit, that there's a lot of concern about this is all very new and very quick, but actually it's based on good science and a history as well. But they are new approaches. There are further vaccines coming down the line as well. So all of these vaccines require 2 doses. And maybe later on we can talk about the fact that why we're spreading out the number of doses more locally. And one of the key things you'll see talked about in the press is about the level of effect, the effectiveness of the virus. And I just wanted to explain how that's calculated, because I think sometimes, what does it mean in practice? And actually, for the Pfizer trial, they tested about, I think it was about 40,000 people. And what they do is they set a bar of how many cases of coronavirus they want to find. And so in that case, I think it was 170 or 200. And what they did was that when you get to that point, you then look at how many people had the vaccine and how many people had the placebo. So in other words, for the Pfizer one, about 180 out of 200 people had the placebo and 20 had the actual vaccine. So that's where the 95% or the 90% effectiveness comes from. And that's effectiveness in preventing mortality and severe ill health. That was the focus of these vaccines. And the reason why you might hear about some of the challenges of handling these vaccines, and Juno and colleagues can really probably talk more about it from a practical perspective, but the Pfizer was the first vaccine we had, but it is pretty hard to handle. It requires storage at -70. So that sometimes controls where and why certain vaccines are used in certain settings. And certain vaccines, some are easier to move than others. So there may be a question later on about can we choose which vaccine, but there are certain practicalities around that. So I think one of the questions is that, so how were the vaccines developed? And they've gone through the same process that all vaccine developments go through. And I'll talk in a bit that's been done at a faster pace and in a different way, but all the stages have been put in place to do that. And the slide outlines some of those stages within that. And I think also to be clear that the vaccines have been trialed on a number of different populations. So we've got the individual different vaccine trials and some very large samples to do that. And to do that in a year is absolutely incredible. And one of the challenges we find actually normally is it takes a long while to recruit participants, but it wasn't difficult for this to recruit participants for these trials. One of the questions is also, well, is it representative of the whole population? So each of the trials have had a proportion of people from different BA/B communities, and also across a number of different countries. So as trials go, actually, they are generally being seen as more representative than maybe some of the historic trials that have been taken place. And ultimately, all the data and information for this has to be submitted to the regulators, and the regulators are involved. So you may have heard the term the MHRA, and that's our national regulator around drugs and medical equipment. And basically they've been involved all the way along, looking at the data, what does it mean in order to speed up the process for authorization. And also these vaccines and the outcomes of them have to go through peer reviewed journals as well. So this slide briefly outlines the normal kind of path for traditional vaccine development. And the normal path can take up to 10 years. So what you'll see in the box below, this one here, is the same development process, but what's been done for this current vaccine. And what you'll notice is that each of the phases are still there. Some of them are a little bit shorter, but what they have been done is rather than do them one after another, they've been done together at the same time. So ultimately, what's enabled us to get to this point is, one, they started on this as soon as they heard about the virus. So it's not that they started this in August. They actually started working on this in December as soon as they started to get the information from China coming through. Secondly, is that we put a huge amount of money and resource at this, recognizing the importance of this. Trials are really expensive and it takes a long while to do them, because actually it takes a long time to recruit people and to do each of the stages. This has had a huge amount of government money from across the world being put in to develop this. And as I said, secondly, some bits have been done side by side. And this means that actually the key stages have been done in this more broadly. And I think the question I get is, well, how do you know it's going to be safe? Don't we need a number of years before we find that out? Well, in reality, actually, even for vaccines on its normal pathway, they're still assessing it as it goes live. So we haven't missed any steps. They've just been done together with each other. And actually what happens is that we get live monitoring as we go along. But this all builds on a history of vaccine development. This isn't just that we've suddenly invented vaccines for the first time. We've got a long history in this. So the JCVI, which is the Joint Committee on Vaccinations and Immunisations, has identified the top 9 priority groups. And at the moment, we're working through these groups with a commitment to get through, I think, groups 1 to 4 by mid-May. And that's why we're really keen to support individuals in the health and social care frontline workers to get vaccinated as part of that. And this is looking at those that are most at risk and hence the importance of prioritising these different groups. And this is very much an evidence-based driven decision around how they've picked up on this. And this is based on the fact that we're still not clear about how effective the vaccine is in preventing transmission. So the core focus is on reducing risk of dying from disease. As I said, so the vaccine's focus is very much around those serious consequences, and that is what the vaccine has been shown to be very good at doing. And as I said, it's not fully known yet about how much it will prevent the spread. So that's why actually the hands, face, space, the PPE, all of those messages are still really important, and we need to continue to follow the guidance around those things. And again, around side effects, the MHRA are monitoring, and they have a yellow card system. And generally, most of the side effects are around mild fever, pain in the arm, where the vaccine is given, and also feeling tired and achy. And at the moment, as I say, it's being monitored closely, but actually the outcomes from the MHRA are showing that there hasn't been any serious other side effects apart from those already reported. And we can talk and answer questions about anaphylaxis later if people would want a question around that. Question around the number of doses. So a couple of facts. One of them is that, first of all, a question might be, well, I've had COVID, so why would I need the vaccine? The reality is that a natural infection of COVID necessarily does not give a prolonged protection. And I think we're fairly clear now that the vaccines give a stronger prolonged coverage from the vaccination. The second bit is about the dosage, and the fact is that the first dose has been shown to be effective to start to build up a response. But it's a bit like when you learn something, you do it once, you actually need to top up a bit later on and maybe go back to that. And that's what really that second booster is about, is that second vaccine is about ensuring that we can keep that level of immunity going forward. And as I said, we've made a decision in this country to spread those 2 doses out to maximize the impact overall. In other words, to make sure that we can prevent the maximum amount of deaths and ill health. And the evidence is growing on that. I know there's some challenge from people saying, well, where's the evidence for this? But that was based on a history and understanding of vaccines. It was based on some of the other data that actually was picked up as part of the trials. And I think what we're seeing is the rest of the world now are starting to think in a similar way to us. And the data is showing that very much that this is the right decision. So last couple of things from me. So this chart is called the Swiss cheese of respiratory virus pandemic defense. And I think the key point from me, and you imagine this Swiss cheese with all its holes in it, is this virus is pretty effective at getting through to people. And these new variants are even more infectious. So when you look at it, actually, we need to still continue with all of the different things, as I was saying earlier. Vaccines are there at the end, but actually, we still don't quite understand the impact on spread. We know that although it gives high levels of efficacy and protection, there's still some people still may get COVID. And also the fact is that as new variants come along, we need to make sure that at the moment we continue to follow the guidance. So from the personal responsibilities around the social distancing, the masks, avoiding touching your face, but also from the wider response around contact tracing, good testing, getting tested if you have symptoms, and quarantine. So these things are all needed at the moment. We still have high levels of virus in the community. It's dropping at a good rate of knots, but we need to follow all these things together for the foreseeable future to ensure that we can we can reduce the spread of the virus at the moment. So I think that that's everything from me, really, Christian, just to try and give a broad opening. So happy, I think, if people are happy to move into maybe the questions and start to work our way through those.
Thanks very much, Stuart. Yeah, we've had a flurry of questions during your presentation there, which obviously gave some insight into the sort of the development of the vaccines and the sort of the process in terms of the rollout. Just a couple of questions grouped together here, really, around whether the vaccine can cause infertility, and younger carers in particular who've looked on things like social media as opposed to sort of mainstream news channels, and have actually been seeing things which have made them concerned about the vaccine possibly causing fertility issues. So I don't know who would like to pick up on that one.
Okay, I mean, Juno or Lauren, do you want to pick up on that at all? Juno, would you be happy to? Or?
Yeah, I'd be happy to, unless Lauren wants to answer it. So the answer really is that it hasn't been shown to cause any fertility issues at all. So before I answer that question in more detail, I'd like to say a couple of things. And that is that I agree with Stuart that there's no such thing as a stupid question. So if you have any questions in your mind, don't hesitate to post them. The second thing I was going to say is that doctors can talk about how safe a vaccine is until they're blue in the face. But if they haven't had the vaccine themselves, people are right to say, well, you're saying one thing, you're doing something else. So I'd like to say I have had the vaccine. And there was a study before the vaccine was actually rolled out, done by Medscape, which said 40% of doctors who replied to the study said they didn't want to be first in line to have the jab. They weren't saying they would never have it, but they didn't want to be amongst the first. What I would say is that I now know of no doctor who has declined the vaccine. I'm sure there are one or two, but of those 40%, practically everyone has now had the jab. And one of the reasons why they've had the jab is that, okay, so the AstraZeneca AstraZeneca vaccine, the Oxford AstraZeneca vaccine had 40,000 volunteers in the trials, but that's not 100,000 or 1 million or 10 million. So rarer side effects wouldn't have come out. But even in the UK, we've now had over 13 million vaccinated. There have been no serious side effects. There have been no deaths attributable to the vaccine. Now, some of you who read more widely might have found that there some people did die, elderly people within a certain time frame after the vaccine. But remember, when you're giving the vaccine to really elderly people, really old people, a percentage of them would have passed away from natural causes anyway. So they've looked at the numbers and no deaths have been attributable to the vaccine. So it's thought to be safe. In the UK, I think it's worth pointing out that 96% of people between 75 and 80 have actually had the vaccine, and 92% of those above 80. So the elderly are very confident in having the vaccine. The other thing I was going to say was that, you know, how safe is the vaccine? Remember that in the UK, over 100,000 people have died out of about 4 million positive tests. So 4 million people have tested positive for COVID, and 100,000, that's an awful lot of people have died. In fact, it's over 100,000, as you know. But 13 million doses of the vaccine, in other words, 3 times as many have actually had the vaccine and no one has died. So the illness itself is massively more dangerous than the vaccine. But a lot of people on today's call, and thank you all for coming, are in a younger age group than the 75 and 80-year-olds. And your questions obviously are different. Your risks may well be lower than older people. And the question that often comes up in the younger group is, does it cause infertility? So the answer is, it is not thought to cause infertility. But that's linked to another question, is can it be given in pregnancy? And the answer is it's not recommended, simply because the trials didn't include any pregnant women. It just wouldn't have been fair to include them in a new drug. But so if you're pregnant, you shouldn't have the vaccine. And if you're breastfeeding, again, it's not advised simply because it wasn't tested. The answer, however, is it safe in pregnancy? Is it safe to breastfeed? The answer is, because it's an inactivated vaccine, it probably is safe, but no one should be telling you that it is safe, because no one actually knows the answer. But the answer, does it cause infertility? Certainly at the moment is not thought to do so. The trials that were done in animal studies, and it didn't cause infertility, but animals aren't human beings. So it is not thought to cause infertility, and the current recommendation is that once you've had the vaccine, that you can then try for a pregnancy if you're planning to do so. I'd perhaps just ask Lauren if she agrees with my assessment there.
Yeah, so I think from an infertility point of view, there isn't any evidence at the moment that it causes infertility. And I know that's a really big concern for a lot of people who are younger. I'm of childbearing age. My risks for getting COVID and having something serious happen to me is low. But I had to weigh those risks up because I also have a young family, and obviously I'm in a job where I'm exposed to COVID. But infertility wasn't something that I was concerned about when I went to get my vaccine. I think from the breastfeeding point of view and from the pregnancy point of view, I think the Royal College of Gynecologists have got really good articles on there. So I think now they are saying, or the Joint Committee of Immunisations and Vaccinations are saying that it is okay if you're breastfeeding. They don't know if it is excreted in the milk or not, and they don't know what effect that has, but they are saying that it's okay. And I think from a pregnancy point of view, when you are pregnant, your immune system is weakened anyway from the pregnancy point of view. So if you're somebody who's a frontline worker, who could, obviously have a lot of exposure to COVID, then you have to weigh up those pros and cons of getting COVID and having a complication, and having the vaccine, which, as Juno said, hasn't been trialed against pregnant women. So again, I think these are just discussions that people are having with their obstetricians, and also there's obviously people out there who are very, very high risk and have medical conditions that means that their pregnancy is higher risk anyway, and having COVID on top of that, it makes it even higher risk. So again, those people are advised to have discussions with their obstetricians as to whether a vaccine is safe during pregnancy for these people. So there are people, especially frontline NHS workers, who are getting the vaccine whilst pregnant, but they're weighing up their risks and benefits.
And just one final point from me. So on one of the trials, obviously they all the women taking part in the trial had pregnancy tests beforehand, but some women in one of the trials did get pregnant. So I think there was about 12 women in the Pfizer trial got pregnant, of which half of those were in the vaccine, half of the trial as well. So again, although they weren't planning for that, in the real world, people were getting pregnant during that time as well. So although the guidance is clear from that, it's just useful to understand that life was still happening in that sense.
Yeah, definitely. I think, I read the same, that people did, get pregnant whilst on the trials, and therefore it kind of puts to bed the infertility claims in itself.
Just got a couple of questions here together. Somebody's asking, is it likely that the COVID vaccination will be like the flu vaccine, in that it'll be something we have to have done on a yearly basis? And also, with regards to the side effects of the jab, how long can they last before you begin to question whether somebody actually had COVID or not?
Okay, I'm happy to take both those questions. So generally speaking, to deal with the second question first, the side effects tend to be very mild. You may feel very tired. Your arm will probably ache. You might have a slight lump there, and you may have a headache. you can get a fever, but that's actually relatively uncommon in my experience. So, you know, a new persistent cough, a new high temperature or loss of smell and taste, that would suggest you've got COVID, and you should get a test done, especially if it's within a couple of days of having the vaccine. After about 2 days, I would say most side effects would have gone. You may not have any, actually, tell you the truth, and a lot of people don't have any. And sorry, what was the other question, Christian? The first question?
The other question was around the regularity in terms of vaccination. So is it likely that with the COVID vaccination, we'll end up in a situation just like with the flu jab, where this will become a sort of yearly occurrence, perhaps for certain age groups?
Okay, so I think the answer, no one knows the answer to that, because no one's had the vaccine for long enough to see how long the immunity lasts. I wouldn't be at all surprised if it turns out to be an annual flu jab. We know that there are different variants coming out, and in the flu, there's a similar thing every year. There's a shift in the sort of flu that's circulating. That's why the flu jabs are actually released so late in the year, because vaccine manufacturers are changing their cocktail of treatments, so of ingredients, so it works against the flu. And as we know that there's new variants, there's the Kent variant from the UK, the South African variant, etc. So inevitably, maybe some of the vaccines that we're working now will not work as well against them as future vaccines that will be developed. So I think there's a pretty good chance that this will be a regular jab that at least a percentage of the population has.
Okay, thank you. Just a couple more, and there's quite a few questions which are coming through now. One is around vaccine development, asking why weren't the vaccines developed in the same way that other vaccines have actually been, and I'm not really sure whether that's to do with the length of development or the actual process itself, but perhaps the panel could comment on the sort of the process that's been used.
Yeah, by all means, Stuart, go ahead.
So I think there's two things here. One of them, just trying to get to it, is one of them could be about how quickly they were developed, and then the second one is that these are maybe newer types of vaccines in the method. I mean, I think the first thing to say is if it's around time, then as I said, it's not skipped any stages, but the reality is, as Juno spoke about, the number of deaths and the seriousness of the situation means that has meant that we've been able to focus energy and to pull these things together far more quickly than we would normally do. With regards to the types of vaccines, as I say, these ones, as Juno said, don't actually put any of the virus itself into us to vaccinate us in that sense, to create the immune response. And I think some of that reflects on actually the ease with which these newer forms of vaccines are able to be developed and to be adjusted and changed. And so in that sense, it's taking advantage of new technologies for us to be able to bring forward these types of vaccines more broadly. But I think it is a common question. I think ultimately we are building on a huge history, and as I say, these newer types of vaccines have been starting to develop before the COVID ones have been put together. So there is a strong evidence and science behind that. I don't know if you want to add anything, Juno.
Yeah, no, I agree with what you said. What I would say is that the newest technology, which is the mRNA vaccine, messenger RNA vaccine, it's also much quicker to get the vaccine up and rolling before it's put into the trials. So it's thought to be a very promising technology to be able to respond rapidly to new threats. So I think you will see more of that. A related question, which I'll just answer now, which a lot of people have, is does this mRNA vaccine affect your DNA? You often see that being on social media. The answer is it does not. And that's 100% answer, because to affect your DNA, it has to get into the so-called nucleus of your cells, and it doesn't get into the nucleus. In fact, it stays outside the nucleus, and within a few days it's broken down anyway, so it won't alter your DNA.
Okay, just to sort of the question, there's a little bit more detail on that now, saying it's not the process so much, it's more about the way that the vaccines were developed, i.e. some of the newer types as well. I don't know if the panel can actually see that on the Q&A.
Yeah, I think I'd like to think that Stuart and I between us probably answered that, but if we haven't, then yeah, please repost the question.
Sure. Just another question here around care staff who perhaps in the early stages, it says some of my care staff were among the group of people who didn't want to be the sort of the pioneers or the first to have it, but of course now millions have been given the vaccine. They want to, but getting access seems to be difficult, and there's sort of they believe they've missed their slot. So Stuart, I don't know if there's a sort of an answer to that, whether you can help at all.
I wonder maybe if I could bring Claire actually in on that more broadly about from providers about, sorry Claire, about how the best way to flag up to make sure those as part of the prioritised providers can still get access to it. Is that okay, Claire?
Of course it is. There's still not a problem if you want to be vaccinated, then basically we've sent out the provider update that goes out every week. It's just gone out at this lunchtime. Explains that you can book onto the Gainsborough site, and there's also one in Bury, and that's a national hub, and there is explains how you do that. And if you're up in Waveney, then they're going to the James Paget Hospital. So we've given all the information to those sites about the care homes, and so you just have to log on. There's a drop-down menu, says your Suffolk County Council approved social care provider, and then you should get through. And if you have any issue, then contact our ACS contracts help desk and we'll help you to sort that out. So yeah, absolutely no problem. And I do know, because I was on a call just about an hour ago, and they're saying they've got over 300 available slots at the weekend, both Saturday and Sunday at Gainsborough. And excellent. The one at Bury, sorry, just to finish, forgot, the one at Bury isn't opening until Monday, so you won't find that on there yet, but as of Monday it will open, so then you can book on there as well. Okay. Thank you.
And I think just a final bit that very much we see it. I mean, talking to CCG colleagues, we want to help and support the staff in the care market to get vaccinated. So there is very much there's no window missed in this sense. You're a really important workforce in that sense. So the system will do what it needs to do to make sure that those people that maybe were concerned at first have changed their minds can get vaccinated, because you're in that top priority group. So there's, as I say, if there's any concerns, then as much as hope Claire doesn't mind me saying this, go back to the ACS help desk and we will make sure we find a solution.
Okay, thank you. And just sort of linked to that, there's a question on here. It says, do we know when unpaid carers in Suffolk will be vaccinated, please?
Yes and no. So we're doing a lot of work on this, pulling together a list. So we have a list of carers that are known to adult social care. Suffolk family carers obviously have lists, and also GP practices do. So we are pulling lots of lists together, and they're hoping to start sending out information, I believe sometime next week. So we should be doing that quite soon.
Thank you. Just to change the theme slightly now, this is a question here, a sort of technical question around vaccine ingredients. And it says, are there any aborted baby tissue in the vaccine ingredients?
I'm happy to answer that one. Okay. So no, there isn't any aborted fetal tissue in the vaccines. There's no pork in there. So the Islamic Society have, basically suggested that, they're happy for people of, Islamic origin to be able to have their vaccines. And there's no, pork gelatin, which was in other vaccines. So I think from what I've been reading as well, basically vegetarian and vegan, are able to also have the vaccine from that point of view.
Okay, thank you. Another one here. What is the plan for children under the age of 16?
So I think at the moment they're conducting more trials. So obviously we know that we need to look at that section of children. Obviously, they're able to have their flu vaccines via nasal, but we're only able to administer the vaccine at the moment via injection. So I know that the Pfizer BioNTech are currently doing trials for that specific group of people. So it's kind of watch this space, really.
Okay.
Yeah, and perhaps I'll just add to that yeah, so the trials only involved children 16 and above and adults. However, there is a subset of children who are extremely vulnerable, often with severe neurological problems, who in discussion with their specialist have had the vaccine. It is, of course, unlicensed for children at that age. It's a personal decision between the specialist and the family of the children, and if the children have capacity, they're involved in that decision as well. But yeah, the children under 16 are not at the moment planned to be vaccinated. That may, of course, change. The aim, of course, was to vaccinate the first 4 priority groups by mid-February, and that's very much on track. And the first 9 priority groups by May, and then the rest of the adult population by the autumn. That's the government's stated intention. It may, of course, change as more trials come on board. Maybe the children will then be included, in other words, healthy children. But as you were saying before, if you're pregnant and you have something that makes you extremely vulnerable, then that's a conversation you can have with your doctor about whether you want to have a jab or not.
Okay, thank you. There's I'm seeing in the chat there's a couple of sort of logistical ones around staff in particular areas being able to access vaccinations at certain hospital trusts and also at Gainsborough. Claire, I'm wondering whether the information that went out on the provider update, I can send this out to attendees after the event, because there are, I know for certain, having read it, there are links to access vaccinations at a range of different sites. So Claire, you correct me if I'm wrong, but I think if people aren't having any joy at particular centres, then there may be alternatives that you can access. So Claire, I don't know if you want to add anything to that.
Yeah, I mean, it has been slightly confusing, unfortunately, because the vaccine went to different locations. So for the first few weeks, it was basically at the acute hospital, which is why Bury was the go-to place, because it's not easy to move that Pfizer vaccine around. But they have stopped vaccinating at the moment at the West Suffolk Hospital, so they don't have any more vaccine, and they're basically on pause until I think they said mid-March when they're going to start doing the second vaccine. So that's why the provider update does give you the latest, because what the government has done now is brought on these bigger centres that are easier to get to. So that's where Gainsborough comes in, and then, as I say, if you wait another week or a few more days, the one in Bury will open as well. So there will be one in Bury, it just won't be the hospital. And then the second question about the drop-in. So that was the weekend over Ipswich Hospital geared up and had a lot of vaccine available for that one weekend. And so a lot of staff were advised to go and just drop in, and maybe Stuart may know better than me, but my understanding is they have to go back to that location to have their second vaccine. It's all part of the sort of clinical governance, but I'm straying into realms I don't know, so I'll shut up.
I think the point to make is about the gap. I know some people are concerned about why have they not had their second vaccine yet. And I think one of the key points to make is that actually we're still, if you look at it, we are still prioritising first vaccines for many people. They're starting to talk about the second vaccine. Some people may have had their second vaccine, but in general, most people have only had their first, as far as I'm aware so far. So actually, as I said earlier, the gap between vaccines in this country, we've talked about up to around 12 weeks. So I appreciate some people may feel uncomfortable. They want to have their second one straight away, but actually they're trying to draw that out to protect as many people with their first vaccine first. And I appreciate, because of that weekend, there may still be some logistical issues, but we are, from a Suffolk County Council perspective, for our staff, looking at making sure, but I think people need to be patient actually, because we are still trying to prioritize people with their first vaccines.
Okay, thank you. Just a couple of questions on here to pick up. How long should someone wait to have the vaccine if they've had COVID? The person in question had COVID over Christmas and was called for vaccine mid-January. Vaccine was given. Will this affect the immune response?
So the recommended time is 28 days from when you first get symptoms of COVID, or when you fully recover, but generally it's the 28 days if you recovered earlier. I think if somebody had had the vaccine before that 28 days, it just means that your immune system is just getting over the COVID infection that you've just had, and then obviously gets exposed to a non-active, COVID vaccine, and then your immune system, which might be slightly weakened by the initial infection, then has to fight the second one. So we generally recommend that you wait at least 28 days after having COVID.
Okay, and also around sort of being exposed to the vaccine, if you like, as a question just come in literally saying, will our bodies cope with having lots of vaccines on a yearly basis? So COVID vaccination, flu vaccination, pneumonia, are our bodies actually designed to cope with these sort of multiple vaccinations?
I'm happy to take that. It's a really good question. The answer is undoubtedly yes. One of the things that a lot of people don't realize is that though there are a lot of people hesitant to take the vaccine, our children are actually given loads of vaccines by the time they're 1 or 13 months old. And if you were to ask the average person how many different illnesses are the children vaccinated against, the answer is 13 between the age of 4 months and just over a year. So we are jabbed against 13 different illnesses, and it ties in with what Stuart was saying earlier. Is it better to actually have the natural infection, or is it better to be vaccinated against a natural infection? I think one of the reasons why humanity has thrived across the planet is that the bugs, which would very readily and happily destroy us, are actually prevented from doing so by the very extensive vaccination program that exists in most countries. So yeah, it's far safer to have the vaccine, even if there are multiple ones annually, or even more frequently than that, than to have the risk of being exposed to these very, very serious conditions. I mean, we sometimes forget that measles, which we think of as a mild illness in this country, in Africa, it kills thousands, or maybe, Stuart, or maybe even be tens of thousands. So we, are living in a little bit of a bubble protected by the vaccines. And therefore, again, I would say have the COVID vaccine. It is going to protect you, your family, and get your life back to normal.
And just picking up on that point from Juno, I mean, the fact is that when we've seen the uptake of the measles vaccine drop off when we did about 10 years ago, I think it was now, we have seen for the first time in this country outbreaks of measles, and unfortunately at least a few people have lost their lives to it. So it shows you how effective these vaccines are. And as I said, we kind of forget about that, especially some of us in the younger generation haven't really known measles being around that much. So actually they play a massively important role. We just in this country, we've seen it. We haven't seen these things for a long while because we've been protected. But if you go out to other parts of the world, yes, it still can run rife. So yeah, very much support what Juno said.
Okay. In terms of the vaccine itself, question here in the chat saying, are they considering having a non-injection alternative to the vaccine? Obviously, the main focus at the moment is on, having the jab, as it were, but will we ever move to a situation whereby the actual sort of, there is an oral alternative to having an injection?
Oral or perhaps nasal. What I know is that I believe that there's nearly 300 vaccine candidates being looked at across the world. I don't know the ins and outs of the mode of delivery, but I'm sure there are companies that are trying to do a nasal version or an oral version. The reason why that would be so incredibly helpful is that you then don't need to have extensive training in giving giving the vaccine, which would massively speed up the rollout across the world. So I don't know. I don't know if Lauren or Stuart know the answers to whether there's any specific non-injectables being developed, but all I would say is they almost certainly are looking into that.
Yeah, no, I agree, Juno. I don't know of any specifics, but I know that, you know, from a company's perspective, they'll be looking at alternative routes of method, especially if they're looking at under 16s.
Okay, thank you. Question here, which certainly our organisation has come across in the past, and I know that Claire will be aware of this one as well. Staff from the BAME community. I have staff from the BAME community, none of whom have elected to have the vaccine. Obviously, this is a concern for me as a manager. This is a manager in a care setting. What work is being done to reach out to those groups who may have specific concerns? And I know that NHS has released a lot of material, and there are case studies and video information available to try and to reach out to those groups. But is there any sort of further research available? Is the panel aware of any additional research that can perhaps help to allay concerns or fears from the BAME community at all?
I don't want to dominate this conversation, but I've actually been involved in this a bit locally. There's lots of initiatives across the country. Locally, a lot is being done through various channels. The CCG has set up a number of live events, which then were recorded and put online. I think they're sometimes badged, what are we missing, or your questions answered. There's been radio appearances and radio chats. Also our MVA team, or Marginalised Vulnerable Adult team, extensively involved in this, as is the ICRE, Ipswich Commission for Racial Equality, and other charities are trying to reach out as much as possible. So the answer is yes. The problem is that, especially within the BAME groupings, there's a lot of social media giving a lot of negative publicity to vaccines in general, and to this in particular. If these questions don't come up in this chat, it is worth perhaps we can address that. But a few things like, is there a chip which is then going to be used to monitor you and control you? And that technology just doesn't exist, actually. And I think anyone who wants to monitor us can do so much more readily using our social media feeds than to put a chip into us. So there's lots of misinformation out there. There is a central source of information which is being developed locally called the SNEvaccine.org. If you just type in SNE, and that stands for Suffolk and North East Essex, so SNEvaccine.org, type into Google, it'll take you to the website. The website is in the process of being improved all the time to make it more user-friendly and usable, and to answer a lot of the questions that people have. But yeah, it's terribly important that group, BAME group, are at higher risk, and yet they are at less chance of them having the vaccine. Whereas if you're at high risk, you really want to say, yes, please, as soon as possible. And obviously, I have had the vaccine, and I'm happy to tell people who've had the vaccine, I feel confident in having it. I think everyone should. And with over 30 million jabs and no one having died or had serious reactions, the only serious reactions were the anaphylaxis, in other words, the really bad allergies that some people had in the first week or so. And therefore, if you fit into this group that had anaphylaxis in the past, that you should actually be given the AstraZeneca vaccine rather than the Pfizer vaccine, as a safety precaution, really. With regard to research, at the moment, there's, I believe, and Stuart and Lauren may know better than me, but we don't know for sure if there's genetic factors which increase the risk of deaths in these Black, Asian, minority ethnic groups, or whether it's due to the fact that there's deprivation, or at the other end of the scale, there are a lot of medics who are from these communities, and that's why more deaths have been seen. for various other reasons than genetics, but I think that's been looked into and researched at the moment.
And just to pick up on that, I mean, yes, from that research perspective, I meant people from our BAME communities are more likely to work in frontline health and social care jobs, but also in other frontline roles more in general. So those within that you cannot work from home from. So I think that discussion around the genetic versus the environment and probably the interaction of two is an ongoing discussion. But I suppose the key bit is that there is a risk factor there with regards to either the work you do, but also some of the underlying health conditions that certain communities are more likely to be at risk from. But I think the key bit for me is the need to have continual discussions and recognise that slogans and mass communication exercise aren't going to help with this. And I think that's one of the things that we're talking about, is that we need to help have conversations. We need to help people feel more confident to have conversations, to share that information. So some of the resourcing we're doing, we're putting into a number of different groups which represent different community groups across Suffolk to actually facilitate on our behalf those conversations, because we're doing this today, but we can't go out and talk to everybody. So the more people we get confident and kind of almost vaccine confident to talk about it, then the more conversations can take place and share those messages. But it is challenging, yes.
Is that sort of, there's one question here, we've sort of gone through quite a few questions, which is great. Why are some healthcare professionals who have wisdom and expertise in the area from different countries taking a stand, even to the detriment of losing their jobs, to not taking the vaccine? It seems as though there's no middle ground. They're all saying it's safe, or they're not saying it's safe. So is that, I suppose, as the sort of general public, is it the fact that this sort of some people are troubled by the sort of debate within the sort of the clinical community, and just wonder why there isn't a sort of consistent messaging? I don't know what the panel, whether you have a comment at all on that or an answer.
I think it would only be a kind of personal one, to be honest. I think, you know, when they spoke about the vaccine initially, I kind of felt the same way. I didn't want to be the guinea pig that was going to have a new vaccine. You know, if I'm speaking honestly, that's how I felt. But it's not just about me. You know, my parents, you know, they organise my childcare while I'm at work, and I'm exposing them when they come and look after my children. They're obviously older and at more risk. And also, you know, yes, I'm young and I'm white. I don't have any underlying medical conditions, but, you know, do I flip that coin? Because there are people exactly like me that have lost their lives because of COVID. And I've got 3 young children. You know, how much emphasis do I put on being the guinea pig and, you know, weighing up those risks and benefits? And to me, once I'd done all of my research and, you know, looked at credible websites, not things that I was getting via Facebook, you know, it just seemed a logical choice for me, not just for me, but for my children, for my husband, and for my parents who were looking after my children. So yeah, I think we're not all, yes, definitely go out and get it, and no, definitely don't want to have it. I think if you have those thoughts that actually I'm not sure about this, then I think the main thing I would suggest as somebody who felt like that was to read credible resources. And, you know, we'll definitely put some links. You've obviously got the Sneed vaccination website. I think it is educating yourself with factual information rather than things that you just read online.
Yeah. Just linked to that, actually, just a comment that we see a lot of information coming through where care staff, for example, have looked up information, and then when you actually get into it, you find it's been sourced from, as I say, something like Instagram or TikTok, or, you know, these sort of sites. I mean, what are the credible sites that people should be looking at? There's obviously things like Public Health England and Gov UK. Are there any other areas where people should really sort of are the go-to places when you're looking to sort of find out more information?
So the answer is yeah, those are good sites, but because there are lots of good sites, but also lots of less good sites, we've tried to put it all onto snevaccine.org, so that would be a really good site. And for those, one of the best links I've seen in terms of trying to convince the BAME colleagues on this call that it's safe to take is that I think the British Islamic Doctors Association, we're going to put that link on the website shortly, the SNE vaccine website, have produced a really brilliant list of mythbusters. That's a really good site. But more importantly, if you go to SNE, that will then link you into all the really good websites rather than trying to search them yourselves. The other thing to expand on Lauren's point, which was made really well, is that 40% of the doctors in that original survey didn't want to be the guinea pigs at the beginning. And that number, I think you would have dropped tremendously, because all of us have different levels of risk. Some of us embrace risk and some of us are very risk averse. Most of us are somewhere in the middle. And a lot of people who said, I don't want to be in the first few 100,000 to take it, because what if there's a 1 in a million side effect that they don't know about? Well, now that there have been 13 million vaccinated in this country alone, there are very few medics who don't want to have the vaccine. But remember that doctors and nurses, just like are just human beings like anyone else. And there would undoubtedly be people who are anti-vaxxers, maybe even amongst the medical community, and especially maybe abroad. So I think that any thing that you saw previously about people standing and saying, I don't think it's safe, we shouldn't have it, I think a lot of those fears have now been allayed, now that so many millions of people have been vaccinated across the world. And a related question, Christian, someone said, how do we know that this doesn't have any long-term effects that we don't know about? The answer simply is you don't. We don't. But do any of us want to take the chance that there might be some long-term effects, rare long-term effects which we don't know about, but add to that 100,000 even in this country who have died, or the 10% of us who could end up with long COVID, which is a really nasty condition where you get over the initial illness, but 3 months later you're still ill with breathlessness, tiredness, heart problems, all sorts of things, as well as mental health problems, where people suffer from anxiety and depression and stuff like that. So even if it doesn't kill you, there's a 1 in 10 chance it's going to lead you to feel pretty ill for months, if not longer. So yeah, we don't know for sure that it has no long-term side effects, but no drug is 100% safe. Whether it's paracetamol, whether it's ibuprofen, what you're doing is you're saying, is the benefit I'm likely to get from this drug much greater than any possible side effects? And we know the answer with the vaccine is yes, it's much safer to have it than not to have it.
Thank you. There's just a little cluster of questions here. Again, these are sort of logistical ones really around accessing vaccination locally. There's a particular one here around staff attending a vaccine drop-in at the hospital, but they need to be registered so they can have their second dose. But the employer has actually been advised they cannot register the employee if they tended a walk-in. Is there any clarification around that process?
So I think this was Ipswich Hospital again, and they advised us that if you haven't yet been called in for your second vaccine, then you should contact the hospital direct, and because they'll have a record of who they vaccinated, and it could be they just need to check it through. So I think that's why they're saying it's not the employer. They need to talk to the individual. So if you haven't heard as an individual member of staff, then you need to go directly back to Ipswich Hospital.
Yeah. And again, what we'll do is we'll sort of make sure that those of you who are attending this event today will share the information that went out in the provider update, giving the links, the contact numbers and the information you need to make sure that you can access the process. There's an interesting question here around somebody who works for a nationwide living care agency. I'm in charge of sorting vaccines for our carers, and the issue is that the carers don't remain in place for 12 weeks, and it's not guaranteed they'll be back in that same place on the 12th week. Is there any thought of being put into living carers being able to access their second dose wherever they may be? I don't know who wants to pick that one up.
I don't mind telling you what we did have a conversation about that earlier this week, because it's a challenge, and I believe they've gone. There was a couple of people on the call that have gone away to look into that in a bit more detail. So we just wait to hear what they got, because I think so. The question we were talking about initially was quite often the carer can't leave the person. So it was about how do they even get their first vaccination, and that was about hopefully GPs would be pragmatic and be able to go to the individual. The secondary one, like you're saying, is what about the second vaccine if that living carer has moved to another part of the country or whatever, or even the county. So I think they were definitely going to look into the whole issue of living carers, because it is a small area, but it's quite complex. So I don't have the answer yet, but they're definitely looking at it.
Okay.
Yeah, thank you. Just to expand on that as well, I agree with you that living carers who cannot leave a housebound individual can be vaccinated, and almost certainly will be vaccinated by their GP, as long as the GP is aware that that carer is there, because they may not be on their list. But GPs are trying to be pragmatic about this, so it would be worth that if, say, you live it with an elderly person who is due to have a vaccine visit, that the surgery is informed, what about my carer who's actually not registered with you? And just a quick thing, that the Pfizer vaccine, which Stuart said was stored at minus 70 degrees centigrade, could not be transported. And that's why some elderly people above 80 who were housebound were not getting their jabs. It's simply because it's only the AstraZeneca vaccine, which was in very short supply to begin with, can be used for that. So hopefully, as the supplies become more plentiful, we're getting more and more of the housebound vaccinated.
Okay, thank you. And there's a final question in the Q&A box. I say final because I know that somebody's got a couple of questions that are on their way. Related local centres, why can't staff who don't drive access the local centres? Government's emphasising there shouldn't be any barriers to actually accessing vaccination.
Is that me? I think well, there's two things there. Local centres, I mean, it's where they set them up, and at the moment I'm only aware of 3 that so whether they'll bring more on later, I don't know. If people are struggling to get to those, then if you could contact the ACS Contracts Help Desk, then Christian will put that in the chat or send it out, then we will look into that and assist you. So if there are people that can't get there, then we will definitely look to help. Okay, thank you. Now, I know that there's some questions that came through on the email, and one of them was around people, will we ever get to a situation whereby it's almost compulsory that staff in, say, health or social care have to have the vaccine to do their jobs? So do we ever get to this situation around compulsory vaccination? Now, obviously, as the law stands at the moment, I know that's you cannot force an individual, certainly in an existing role, to have a vaccine, but does the panel think we'll actually get to a position whereby it'll become almost like an essential element of a role whereby we do move to that situation?
I don't think so. I think, you know, obviously we're offered the flu vaccine every year as part of healthcare professionals. It's not mandatory. Obviously, it's encouraged because you're seeing people who are vulnerable. So again, this is where I come back to the vaccine isn't just about yourself, but it's about the people that you treat and the people that you see. But I can't imagine that, you know, obviously I might eat my words here, but I can't imagine that the government would ever make anything compulsory or mandatory for you to do and not be able to work if you haven't had the vaccine.
Okay. My only question to that, Lauren, I'm just trying to understand, is there certain vaccine, Hep B vaccine for clinical staff and that? Are there some that from a professional perspective, there's an expectation as part of that That's the only question I have about whether that could go down a similar ilk to that.
So I don't think I was ever told that I had to have it,
Okay.
but I know that I had the conversation that if I was doing things, you know, kind of surgery mainly, so obviously where there was a lot of blood involved, that I should have it. And again, you know, again, it's protecting yourself rather than protecting others at that point. I don't think we ever got to the discussion that if you didn't have it, you were not able to then go into surgery. But it's highly encouraged.
I mean, we are moving into one of the things that obviously you might have seen in the news is this idea about vaccine passports and what that might mean. And there's rumours that Saga for their cruises will only allow people on if they've been vaccinated. Now, I don't know practically how they could do that because we don't have a digital passport at the moment. If you get vaccinated, many people get a little piece of paper card with their name and details on there, which could be easily copied. But I suppose the challenges, and I'm not trying to alarm people, but this is where there is a lot of ethical discussions around this at the moment about what it means. But there may be certain things and certain events and certain businesses that may start to say that we do require people to be vaccinated. Now, there's a practical aspect to it. There's an ethical aspect to it, but I'm aware that there are some businesses that have started talking in that way. Now, that's a big step change, as Lauren says, and I'm not advocating either way, but I think in the sense of just being clear, we may move in that direction for certain areas. So it is something for people to consider. We're not at that point yet, but I have heard that discussed in a few arenas, and I'm not saying that to try and scare people, but that's been discussed in the background in a few places.
So that's a good point, and I think that it's more likely. Again, this is just my opinion, that it may be individual employers who might require it, but also they probably require it simply because of the vulnerability that you, as the person working with the organisation, would have. And as I say, with such a safe vaccine, you know, why would you not? I think it's unlikely at this stage that it will be a governmental national requirement, because say in the States, United States of America, certain states will not allow your children to attend school unless you've been vaccinated. We've never gone down that route here. But I suppose, really, Stuart, I would guess that it depends on how effective we are at controlling this pandemic.
Yes.
If enough people are vaccinated and the pandemic can be declared over in X number of years, then we wouldn't have to go down that route.
Okay, thank you. Just a couple more questions are coming through here. If a carer does not have the vaccine, can you limit the clients they attend, i.e. the clients with more serious illnesses? And again, I suppose that's really linked to the discussion that we're having at the moment around the nature of role and perhaps the exposure to the client or to the carer indeed of a serious illness.
I think that's really answered by the last one, really. I don't think we know. And again, both would still be vulnerable even if you did that. So I'm not sure that would particularly work.
And a practical element to it as well, that how can we ever be assured? So I think from a business continuity perspective and a safety perspective for everybody, it'd be quite a challenging model to run, I would have thought. But yeah, there's a lot of this which is going to need to be worked out in the forthcoming months, I think.
Okay. And one question here. Care workers are contacting their clients' GPs to advise that they are with their clients as living care workers. The surgeries are advising our care workers they are not eligible yet and need to wait to be called. Have all GPs been given the list of eligibility? And does this differ across practices, as the answer they get is variable? And I'm guessing that there is some variation across practices, but I'd be interested in the panel's comments on that.
So I know we discussed this in a call earlier this week, and the answer was that there is no list. So the GPs, if they've been advised that, then it's incorrect. So the CCG were going to go back and talk to the GP practices just to remind them that they, wherever possible, like you say, if they can't leave the carer or they're cared for, then they should be vaccinating them.
Yeah, so but I think the answer is slightly more nuanced than that, and that is that it fits in with the previous question as to who is eligible. Okay, so if you are a paid carer, remember you're in priority group either 1 because you work in a care home, or priority group 2 because you're a health and social care paid carer. You are eligible. If you're not a paid carer, and the vast majority of people in this carers in this country are family carers who do an amazing job, and I think the estimate is that Claire would know better than me, maybe 10 million people are family carers here. Unfortunately, your turn in theory only comes up when your eligibility comes up based on your other things, such as your age or if you're very vulnerable, etc. So the reason because this becomes complex is that if you are registered with a practice, they do have the list of eligibility. But if you're registered with another practice, then you won't have that list. Okay, so if one had a paid carer who was registered with another practice, you would have to just take the word of that paid carer that they could have the jab. Whereas if they're unpaid and it's a family care, in theory they can't give it because they just won't be on that list, even if they're registered with that practice, simply because they may be, you know, beyond priority group 9. You know, so it's a fairly complex answer to a straightforward question. It almost, if you're a paid carer, then I think that the GP could be flexible. As long as they were sure that you were paid carer. I don't know if Lauren wants to come in on this one.
Yeah, no, I think I agree, Juno. I think the problem is it's the information that's provided to the GP for that pool list to happen. So I've been doing the vaccinations at the Mix in Stowmarket, and we've obviously got a lot of carers coming in with, you know, bringing in their family member, whether it be a wife or you know, daughter or son. And asking about the vaccine because they are an unpaid carer, and I generally have been telling them to call their GP if they're not, you know, you basically want it coded on our system that you are a carer for that person. And I think a lot of it, you know, unfortunately comes down to discretion of staff at the time, and also where we are, you know, with the vaccines. If we're day 3 and we've got a few hours left of the vaccines in the fridge, then I know that we've then been vaccinating some of those people. So but I've basically been telling them to call up their GP and get them coded as a carer.
But I think unfortunately, as a rule stand, that Claire says that might be about to change. If they're an unpaid carer, family carer, they don't fit into any of the priority groups, then in theory they're not eligible. But as you rightly say, Lauren, the biggest sin here is to waste vaccine. And if you vaccinated everyone that day who's going to turn up and there are spare vaccines in the fridge, it's best to use them rather than say, sorry, you don't fit into any.
Exactly. And they go into the bin, definitely.
Yeah.
Okay.
You don't want to bin any. You don't want to bin any vaccine.
Yeah. But I think also it's dissemination of information. I think sometimes, unfortunately, for things to go from the CCG level and that information gets trickled down to the actual GP that's answering the telephone, whether it be a locum, a salaried or a partner, sometimes that information just takes a little bit longer to get down. So, you know, apologies if you've had the wrong information when you've called up the GP practice. If that is now the case, but sometimes that information just takes a little while to get into our heads.
Okay, just conscious that we're coming to the close of our event now, and I've got a little cluster of questions here for the panel. First one, is the vaccine safe for people who are allergic to penicillin?
So it is safe. So there's, if you go to anaphylaxis.org.uk, they've got a really, really good website if you're somebody who is prone to anaphylaxis with various different things. Penicillin is #1 on their list, and it says that it is safe for you to have the vaccines if you are allergic to penicillin. The main one that is in the vaccine is the polyethylene glycol. that is quite a rare reaction for people to have. That's in the Pfizer vaccine, so they generally recommend that you then have the Oxford. So I know a few people have kind of put, can we choose which vaccine we have? Although you can't turn up on the day and say, I'd like to have this one if there's no valid reason, anaphylaxis is one of the ones where you might be recommended to have an alternative vaccine, which would generally be the Oxford vaccine rather than the Pfizer. Hopefully that answers the question.
Yeah, sure. And are the side effects after the second jab likely to be worse?
I think there's some anecdotal evidence that it is, including in people who've had COVID and then have a jab, that they get more in the way of side effects than the first time around. But I don't know if that's proven. But even after the second jab, the vaccine, because lots of people have had the second jab, or a percentage of people have, they've been a little worse than the first time around, but nothing severe.
Okay, and just a couple other ones here. My partner is at risk due to asthma and has not yet been invited to receive vaccination. If I visit to get vaccinated, is there an increased risk to her from me having attended a busy vaccination site at a hospital or from the vaccination itself? Is there any way she could be vaccinated at the same time, or I could let her use my dose?
So you can't allocate your dose to anybody else. Unfortunately, she'd have to wait until she received her invitation. I think from someone who works at the vaccination sites, they are extremely careful. So there's social distancing the whole time. Everybody has to wear a mask. If not, masks are allocated. Everybody's kept apart. I've done various shifts there now, and touch wood, haven't caught anything. So I think, obviously, again, it comes down to risk and benefit, and the benefit of you going and having that vaccine is a much bigger benefit than the risk that you're exposing yourself to.
Yeah.
Yeah.
And linked to that, I see here, I'm uncomfortable waiting inside for 15 minutes post-vaccination, as I have read a great deal about poor ventilation being an important factor in the spread of the virus from person to person. Would I be able to wait somewhere outside instead? Well, I suppose that depends on the site that you're actually at, as a rule. Would that be correct?
Yeah, because I know at the mix you don't go into a waiting room. You basically all have your own cubicles, which you have your vaccination in, and then you sit in that cubicle until your 15 minutes is up and are able to leave. I think the main thing is that you need to be, obviously people have to be monitored for the 15 minutes with the Pfizer vaccine anyway. So if you were then outside or sitting in your car, for example, you wouldn't be being monitored if anything were to happen. But like Juno said, we've done millions of vaccines now, and we've had very, very, very few side effects, if not any.
Okay, and the final question that I can see on here, I've been told to wait for the AstraZeneca jab. How will I know that's what I'm booked for?
Well, I mean, if you've been told that, whoever told you that should make sure you get the AstraZeneca jab. So it may not be as complicated as one thinks. There is often, if I'm not mistaken, Lauren, is there availability of both sometimes on the site?
So there is at the bigger sites. So I know that Ipswich generally has multiple vaccines available, whereas the smaller hubs, Haverhill, Stowmarket, etc., generally only have one. Yeah, I think the problem is that sometimes people are getting misinformation. So I've had a lot of people who have come in saying my GP said I need to have the Oxford, but I'm here now. And actually, when I go through their allergies and the reasons for that, there is no reason that I can see. And I've then given them the vaccine they've obviously been happy with and not had any reactions and left with their vaccine. So
okay. Thank you. So I'm sure that after the event, people will have loads of questions, because that's always the way with these things. But if that is the case, that's not an issue at all. If you just direct those to info@caredevelopmenteast.org.uk, jesuthasan.co.uk, which was the original address on your joining instructions, then I'm sure the panel will be able to pick those up after the event. The webinar itself has been recorded anyway, and I saw a few questions around the slide presentation, and obviously the presentation is included within that recording, so you should be able to access that. And I would encourage you as well to share the information and the discussion that we've had today with any colleagues or with any sort of people you work with who have concerns about vaccination, because I'm sure you will agree with me that it's been a very enlightening and insightful event today. And I would like to thank our panel, Stuart, Lauren, Claire, Juno, and Molly, who's been there in the background helping myself to multitask and pick up all these questions. So again, thank you very much for attending today's event. Juno, did you have
Christian, could I just say one thing? Thank you so much for everyone who's come. There are 9 initial priority groups, 1 till 9. And in the first priority group, there are elderly in care homes and staff working in care homes. Number 2 are the 80-year-olds and over and health and social care workers. Health and social care workers are therefore in the top 2 priority groups. It just shows there's a significant risk for you. So please seriously consider having the vaccine if you haven't already. Those people who are extremely vulnerable, clinically extremely vulnerable, actually only have the risk of serious illness of a 70-year-old and above. But those of us who are working either as in the care sector or the health sector actually have a much higher risk than even them. So it's a safe vaccine. Please give it some serious thought about having the jab and protecting yourself.
Thank you very much, Juno. And again, thank you to our panel, and thank you all for this afternoon, making it a really useful and interactive event. Thanks very much. Bye.
Thank you. Bye.